So we're going to get started today. This is a panel, so no slides. You're just going to hear us talk, and we'd like this to be as interactive as possible. So if you have questions while we're speaking, please feel free to raise your hand and ask a question. I have a volunteer in the front here who will run around with a mic so we can all hear what you're saying. First off, we're going to do a quick introduction about who we are, our role in the healthcare identity space. But real quick, I'd like to get a sense of the room. Who here comes from a healthcare vendor, works in the healthcare space, is a provider, a payer? Okay. Who here is a patient? Okay, good. We all recognize we're patients. Who here is not in the healthcare space? Maybe you're from an identity vendor or sort of work in that sector and you're just sort of learning about it? Very good. Good. Then we have the right mix of people in the room. So my name's Catherine Schulten. I'm a product manager over at a company called All Clear ID, and I'm going to be moderating this session. These are the real smart folks who are going to be answering the questions that I'm going to be posing to them. I might chime in with an opinion or two. I'm known to do that. So let me pass. Don't laugh. Let me pass this on to Eve first up.
So hi, everybody. Eve Mailer with ForgeRock. I'm VP of Innovation and Emerging Technology there. A little bit about me. So in the context of this panel, I thought I'd describe myself as kind of an analyst and strategist and innovator, and my particular interests are in creating successful wide ecosystems that empower individuals. And so in that context, some of the interesting things, I hope interesting, that I've worked on are founder and chair of the User Managed Access Standard, UMA, also co-chair of the Health Relationship Trust Profiles, that's HEART. And one of the things that I'm hoping we'll talk about today, the topic I'm most keenly interested in, is how real-world relationships and changes in those relationships impact how individuals achieve better health through digital means. Over to you, Rosemarie.
Hello, everyone. Rosemarie Nsahlai with ONC, Office of the National Coordinator for Healthcare Technology. My role is in security, and I have been with ONC a little over 4 years. I'm passionate about healthcare. Came into healthcare from diverse sectors: finance, oil and gas, consumer product, and I'm really excited about creating sort of improvements in healthcare and hoping that the diverse groups of folks here would really understand why establishing nationwide connectivity will reduce patient burden, will really allow patients to have access to critical information which concerns their health, so they can have better health, and we can really reduce the cost of healthcare and really improve how we treat patients and consumers alike. So establishing that is one of the foundational core of ONC, improving patient relationships, establishing trust, allowing data to flow as needed when it's needed, so patients can get treated, consumers can get treated, and really establishing a broader framework for trust and scalability in the marketplace for identities.
Ryan Howells, I'm a principal at Leavitt Partners. We are a strategic healthcare consulting firm that was founded about 10 years ago after former Secretary Mike Leavitt left public office. We do traditional strategic consulting, but we also are conveners. We convene industry stakeholders to solve difficult issues. One of those convenings that we organized about 2.5 years ago is called the Carin Alliance, C-A-R-I-N, and it's on the web, carinalliance.com. Encourage you to write that down. You can see some of the work that we've done on identity on that website. And we have specifically looking at the idea of how does a consumer be able to aggregate all of their clinical and payment information to their mobile or desktop device, where, when, and how they want to achieve their goals. We have about 50 stakeholders involved, including all the major health plans in the country: Humana, Kaiser, Aetna, Blue Cross Blue Shield Association, and others. Apple and Microsoft are involved. We have identity providers, we have application companies, and others, all trying to solve that particular problem. And so you have chosen the right session for today, by the way, because healthcare is a $1 trillion market opportunity. So if you're looking at total accessible market, this is the place where you want to be. And we're from healthcare, and we need your help.
that's probably the big theme we want to get across. If there's anything we want you all to come away with, is the understanding that the healthcare sector really is challenged by issues of patient identity specifically, and that's what we're going to talk about today. But we'd be interested in your thoughts, even if you're coming from another industry sector. So that actually brings me to my sort of first question I want to ask the panelists. Sometimes healthcare thinks of itself as being a special snowflake. We're unlike anyone else. No one else has the struggles we have. But really, we have a lot in common with some other sectors, and I think about like the financial sector. We're both highly regulated industry sectors. We both have, all the consumers in the United States, across the world, who are, potential users of the goods and services healthcare provides. We have to do electronic transactions in numbers that are just staggering, and we have to do them highly secure. And there is zero tolerance for getting it wrong. And in fact, I would say in this way, we are a little different than the financial sector. If you get it wrong in the financial sector, you deposit $1 million in my checking account and go, oops, that was a mistake. There's recovery for that. If you expose my health information, or you misinterpret and think that I'm someone else with the same name, and you commingle our medical records, that it could be a life-altering event. So the patient safety implications of getting it wrong, I would say, are more challenging and more serious than in the financial sector. So I'd like to ask the panel, what do you think about the healthcare sector looking to other industries? Those in the room, if you have thoughts about what could we learn in healthcare from other industry sectors. Toss it over to anyone who wants to take that one.
Well, Catherine, we can learn a lot, I think, is the answer. I think, first of all, maybe we can set the groundwork for really where we've come from. Like, what is healthcare? Because there's a lot of people in here that don't have a healthcare background.
Good idea.
So 10 years ago, we in healthcare literally didn't even have a legacy environment, okay? So when you go to your local provider, they would fill out a clipboard and they'd have all those different rows of file folders, right, that were there. They didn't even have, nothing was on a computer, right, about 10 plus years ago. The government was kind enough to give us $40 billion, right? So thank you for doing that. If you're a VC firm, it may have taken less than that if that was the case. But since we're a highly distributed environment, it took about $40 billion to do that. When they gave the healthcare industry $40 billion, then within about 5 to 6 years, 7 years or so, we got to about 95% market penetration on just building a legacy environment, okay? So we have back-end legacy systems that are 20 plus years old now. Hey, all right, that's of about 5 to 7 years ago, okay? So that's step number one. That's both on the provider side and the health plan side have had the legacy environment for a while. Step number two is we needed a way to exchange the data, and we have cobbled together different things over time to try to exchange the information, but they're using things like EDI and things that are very highly unsecured and just ways in which to exchange the data that are extraordinarily antiquated. Part of that has to do with what we call the regulatory box that we're in. It's called HIPAA. I'm sure you've heard of that even if you're not in healthcare. It's a regulatory box that says anytime we exchange data within that regulatory box between providers and payers, then we have to follow certain guidelines for how to protect the information, but we also have to use certain standards, and those standards are 20 plus years old. They're mainly EDI X12 standards. So, we're trying to get that right. Now, the problem with exchanging data in the HIPAA box is that we have all types of competitive reasons as to why we would never exchange the information. What's not really contemplated there at scale is the idea that a patient needs to be able to have their medical information be transportable to whatever doctor or hospital they go to. And some of those hospitals compete in the marketplace and they don't like to share patient data, regardless sometimes of potentially the effect it could have on the individual patient. So the government stepped in again and said, you should mandate the fact that this needs to be done and you should make sure that happens. So we have a level playing field now that says, we are now going to mandate the exchange of the information between these different entities. Point number three is we also need to modernize our architecture to RESTful API standards. So this concept of APIs is about 5 to 6 years old in healthcare, literally, okay? Now, the good news is it's really significant. It's a technology called FHIR, F-H-I-R, Fast Healthcare Interoperability Resources, through a standards-making body called HL7. That specific API infrastructure is now being implemented at scale through industry consensus bodies for both the health plans and providers as we speak. Government's helping us because they're saying, go do that. Private sector saying, that makes a lot of sense, let's agree on the standard, make it open so anyone can make that happen. Within the next 3 years or so, we should see APIs across the board. But we very quickly get to our final issue. It's not necessarily our final problem, but the idea of digital identity. So we can have all the APIs in the world. We don't have a secure way to identify users across systems. We have a problem with that. So literally just this year, we've started to, well, 2+ years ago, the Karen Alliance, which I'm in, said, hey, this NIST thing that's 863.3, this is awesome. Like, everybody in healthcare should implement IAL2 or AAL2. I remember being at the ONC meeting and they were going, what in the world is he talking about? Like, I don't even know what this is. I don't even know what this is what's going on. The good news is ONC, with others who have kind of come to the table, said, yeah, this is a good idea. They've implemented it in some of their policies as well. So now we're really starting to talk about digital identity at scale. We are trying to get to a point where we can develop an open framework that allows for all private and public sector partners to be able to exchange information using that digital identity and authentication infrastructure that allows for the APIs to flow, whether it's within the regulatory box of HIPAA or outside the regulatory box to third-party apps that consumers can actually control and manage their information. So that's where we are today. Anything you'd want to add?
Just a question. Is there anybody here who represents healthcare interests from outside the U.S. where things look really different? No? Okay.
No.
So I just wanted to make an observation that, like, from one perspective, thinking about healthcare versus, say, financial services, everything is completely different because there's different regulations and those subtleties, amount to a whole lot. There's different history. There's different business models.
Oh, yeah.
And I've been in rooms with, financial services customers, for example, versus healthcare customers where each one is convinced that, their use case is way more important. Like, oh, yeah, you could talk about bodies, but, $1 million is way more important. Or you could talk about $1 million, but bodies are more important. Right. And depending on, what side of the equation you're on, you feel one or the other more keenly in the moment. But in certain other respects, I think at the technology level, identity solutions and standards have matured to the point where certain things through certain lens look remarkably similar.
Exactly.
So, the identity proofing and the identity verification conversation in healthcare looks like what's called patient matching. Mm-hmm. And we've been debating among ourselves, well, is it the same thing? How close is it? And to a first approximation, it looks like the same problem. Yeah. And I don't know, I want to delve into, you experts. Right. All right, really, what's different? I don't get what's different.
Person matching, so this is a concept in healthcare. I'm not sure if you're aware of it. When you go to the doctor's office and you go to check in, you tell them your name, you tell them your date of birth, and someone types it in, and they look for your record based on that information. So if you are unfortunate enough to have a name like George Williams or Maria Garcia or something like that, there could be...
Well, my old boss, Bill Smith, I always said he should be called Fabio Smith because it would at least distinguish him.
There are 15 other different people with that same name in that system. So you are at risk if that's the case. Does the financial sector or other sector have this issue where there's an attempt to try to match records just based on something like they share the same name and the same date of birth? Is that going on?
So KVA is, we know about, KYC, the KYC process. Mm-hmm. And it's used to do proofing, right? I mean, we've got processes. We know about, like, the recent guidance for government agencies to stop using the credit brokers to actually do their KYC processes because that data is not secret anymore, and there's other methods. Do you have any? Can you talk about that guidance?
No.
Putting Rose on the spot.
I'm from the government and I can't talk.
Right.
She knows everything, but she can't talk about it.
Yes, you're right. So healthcare and financial sector, I think they are similarities. But then there is a lot of data involved in healthcare, more so than financial sector. And I have Phil from Early Warning that can talk a little bit about the financial sector data exchange, because in healthcare, it's longitudinal. So all your records get added exponentially from a simple CT, you might have an X-ray, a CAT scan, and all of that record makes your complete picture. While when you open a bank account, you may just have 1 or 2 encounters and you're done. And all you do is use an ATM card, get your money, or deposit money, or transfer money, get a mortgage, and those are one-time events. In healthcare, we have frequent flyers that are constantly in the ED, constantly seeing physicians. You have annual checks that you have to do. So it's the data volume and the ability to leverage the use of APIs that Ryan talked about is critical, but I also think private sector in any sector has an opportunity in healthcare. It's $1 trillion market. The EBIT is the highest in the sector in any industry. So there's an opportunity for the private sector to come in, layer on top what healthcare already has, layer on top all the electronic health systems that ONC has taken a lot of efforts to promote and ensure that records, patient health information is kept electronically and is accessible remotely through patient portals. So I think any private sector organization, regardless of the sector in which they operate, can definitely come into healthcare at this point and layer on top what healthcare has. Because healthcare doesn't have competencies in identity. And from what Ryan said, we kind of moved from this $40 billion from high tech, get your systems electronic. We moved from paper to electronic, but there wasn't a format to it. There wasn't standards established for it. There wasn't a long-term process for scalability. We simply took paper to electronic and nothing in between. So now you have a lot of data mining that takes place, data reconciliation, dictionary lookup. So there's a lot of opportunity in healthcare for improvement. But with that, I will like Phil to kind of talk a little bit about the financial sector. Thanks, Phil.
Hello.
Okay.
All right. Hi, everyone. Phil Lamb from Early Warning. Just responding to your question about is there a difference? I think I agree with the panel. There is a difference. We had the same problems as matching, customer matching for our standpoint, but the risk tolerance is very different to your point, right? It's something that we can calculate for and mitigate against if something goes wrong. We build it into the system, and that's okay. And that's what has made it successful, or as successful as we can, so that we can keep working towards the problem. So when you have your risk threshold, if it's at that level, that's where I think this group and innovators in this space can really help. Try to help solve that problem. So that just to answer that question there.
Yeah.
So just to give you an understanding of how significantly important this problem is, if that legacy system that I mentioned at a provider's office is called an electronic health record, or an EHR. So we have one of the largest integrated delivery systems in the country that we spoke to recently, and they said they've got the same electronic health information system on-prem solution that they've essentially delegated the customization of the registration portal to their individual units. So as you can imagine, kind of a garbage in, garbage out type scenario, right? So they're not getting the right demographic information in there. Once they get that information in, then they've got to figure out how do they match those records across the individual distributed environments in a way that is consistent and all those records actually match up to the person. They spend $30 million a year doing that. They have the same back-end system. Now, there are, whatever there is, 2,500 hospitals out there that have the same problem, if not worse. This is a huge opportunity. And so you say to yourself then, how do you as an identity provider integrate into that environment? And that's the problem that we're trying to tackle in Karen right now, which is regardless of whatever your legacy environment is, we need to have an environment that sits on top of that, that does identity authentication, federate consent, and do it in a trusted manner using open standards that then can then be able to send that API information back into the legacy environment so that they can be able to accept those digital credentials in a trusted way. That's what we're trying to tackle.
So I had one question.
Yeah.
Just on this topic about patient matching. I'm just responding to a comment from the congressman yesterday morning.
Thank you, because I was just getting ready to say it.
Where he was advocating for a national patient identifier. And I think from a purely scientific perspective, that makes sense for him in his mind.
Yes.
And wanted to see if the panel had a reaction to it or.
I had a visceral reaction to it.
Me too.
Yeah. So after I did that, I think we can all probably appreciate some of the challenges that come with enumerating every person in the United States who is going to get health care. And that doesn't mean citizens. That means people. You could be visiting for a week from some other country and fall down and hurt yourself. You would have to be identified. You could cross the border, be in this country illegally, and you hurt yourself and you need to go to the hospital. You would need to be identified. Every person who gets health care would have to be identified. That's the only way that this works. So there are those concerns about, well, who gets an identifier? The political, you're going to come up against a wall on that one right there. Then there's just the whole, well, then who does the enumeration? Is the thought that there's some big government agency, like we all got Social Security numbers, who's going to just hand out cards to everyone and we're all going to have a number? I think that probably frightens some people, and the privacy implications of that are huge, and the cost of that. RAND study done however many years ago, what was it, in the billions of dollars that it would cost to roll something like this out. So those are just some of my first reactions, and I don't think an identifier solves the problem. We had Social Security numbers used for many, many years as one of the identifiers that we use to match on. Doesn't work. Doesn't work because people lie about their Social Security numbers. They make up a Social Security number because they don't want it tracked. Digits are mistakenly transposed. It just doesn't work. But let me toss it
One of the thoughts that I've had actually for a long time, being in identity for a long, long time, is it's easy to point to certain smaller countries and say we're behind, and no disrespect intended to them, but they're pretty much the size of a good POC.
No disrespect to
compared to the U.S.
Yeah.
The U.S. is large and complicated and has certain cultural factors and certain jurisdictional factors because we have many layers. And so there's a lot of things going on to consider a proposition like that, and roll all that up, and it adds up to maybe not the solution that you think it might be.
Right.
So
And
maybe,
also-
go ahead.
Sorry, and from an HHS perspective, that whole concept was banned by Congress. There's a U.S. law that prevents HHS from working on any sort of national patient identifier. And while I'm not a proponent of regulations per se, and I work for the government, this is actually a good thing because I don't think it would solve the problem of the patient matching fundamentals or even identity crisis we have in healthcare. I think there are other solutions that could potentially bridge that gap, but definitely having an overarching organization to oversee the process and create the framework, such as Karen bringing a collaboration of large organizations like Early Warning did with all the large banks, and come up with a methodology for how to identify people to access systems and how to scale identities. That's something that the government is really interested in looking at.
Yeah, so just to be really clear, there was a ban on the Department of Health and Human Services from funding any research related to establishing a national patient ID. Next week, Congress, the Senate specifically, is going to vote on a Department of Health and Human Services funding bill that's going to lift that ban so that HHS can now fund research into how they may establish a national patient identifier. I may be the only, it sounds like I'm the only one on the panel that's optimistic about this, and I'm optimistic because of the following. Number one, there's money. That's great, right? Number two is the idea that we could actually fund an approach, a process, that could potentially get certified that involves both public and private sector partners to then be able to establish the issuance of another authenticator, which this would be, but tie it to a proofed event, right? And tie it to OpenID Connect and OAuth and the ability to be able to then link that back. There's an opportunity here that's monumental if in fact this goes through, if in fact we can agree on the process, the certification, all of the things that need to happen in order for this to move forward. So maybe I'm a little too optimistic.
I saw someone sitting over here. Did you have a question, Steve? Yeah. Yeah, there is coming to you.
Thanks, Dion.
Thanks. Steve Wilson from Australia. Not from the health system in Australia, so I didn't put my hand up. We do have a national health identifier in Australia. Nobody knows what it is. It was issued 10 years ago en masse to every Australian, and it's sitting in a database. Now, if you want to use it to index a health record in general practice, the doctor will ask you for your consent, and then you give your Medicare number, your date of birth, your gender, your full name. They send that in a package to Canberra, they wash it against the database, and they come back. Now, Eve said before, no, Eve or Catherine said that there's a lot of false positives when you use name matching in the American system. The problem in Australia is false negatives.
Oh, yeah, both.
60% of the time, when you try and look up that unique national record, it doesn't match at all. So the system's almost unusable. Now, so I guess the point I wanted to make was that I think that what happens in healthcare is that the problem that we want to solve is, are we dealing with the right person? So instead of identifying them per se, it's going to be more about can we find out what we need to know about them in context. So it might be that they're in a mental health database, and I want to know that. And I don't want to have their personal information or their personal identifier at all. I want to have a pseudonym to pull me out of a mental health database, or a clinical trial, or a possible specific record locator. So I think what we're not doing really well in identity management and in healthcare is working out how do we convey those specific things in context. And I'm wondering if the panel's got any perspectives on
No, you're absolutely right.
authentication as opposed to identification.
Identity and context is huge. There is I need to know it's the right person, but then there's also the context in which that person finds themselves. There's context based on the treatment, mental health, AIDS, other things that are just like super secret. Then there's the context of, is this person a minor or under, parental control, that they don't necessarily have the aptitude to be able to manage their own medical records, so someone else is doing it on their behalf. So there's a lot of contextual things that go on in healthcare. The other, big thing is that, healthcare, while it's a huge issue financially to get healthcare or pay for healthcare, everyone has a right to get care. So if you're injured, you're not going to be turned away. Whereas if you go to a bank or some other place and you're like, I'd like $1,000, I can get turned away. No, go away. You don't get that. But in healthcare, that really isn't the case. So people have a right to anonymity. They have a right to not be known when I come in for some service as well. So there are some contextual issues that I think are unique. But
well, these are some of the absolute trickiest things, and it does make healthcare, I'm going to say, a special snowflake, as you were saying at the beginning, because some of those longitudinal aspects, like there's so much data, and it does go across, the same body across a whole life. That actually could enable some better fraud detection than you might get in financial services or other things where it's maybe less consequential. But it also means there's more consequences to, if you wanted to sort of exercise a right to be forgotten or something, you might get less good care or something if you didn't want that body of data to be used in the exercise of health care with respect to you or something, or something similar like that. Anonymity or pseudonymity around care for yourself. Also, some of those relationship-based things. Relationship, for me, is the word of this conference, because it's like we're going beyond a single identity or digital identity to all those relationship questions, and these are some of the things that are actually coming up in UMA and in HEART, how do you manage sharing data about somebody who's in your care or somebody who's too young to consent that you're a guardian for, things like that. These are things that are solvable, but you need a layer above. You need to start looking at multiple identities.
Yeah,
and
we need a
relationships
layer
between them.
of identity expertise
Yeah.
that I think healthcare industry sector
is-
is sorely lacking.
This is doable, by the way.
Oh, yeah,
this
it's
is,
technology.
this is doable, and
One question over here.
people are
with the
working
mic.
on this.
Yeah.
Come talk to me.
Go ahead.
So I think we're talking a lot about the edge use cases that make patient identifiers not a good thing.
Mm-hmm.
But for 80% of the use cases, maybe it is a good thing. And if you tie that to some kind of distributed identity or self-sovereign identity where you own your record, you could pull out a lot of cost and improve a lot of lives by solving the 80% and treating the remaining 20% the way we do it today, right? Which is not ideal, and but it is the way we do it today.
Yeah, and I've heard that statement before, and there's some truth and I think goodness to the fact that a large number of people in the U.S. have health insurance. As a result, we have an insurance identifier, a group identifier, and these are common enumerators that are unique and special to us. But you change insurance, and now you've lost your enumerator. Or just your employer decides, we're going from Blue Cross to Aetna this year, and yeah.
But
it goes
that
away.
is the core use case, right? So 160 million Americans are employer-sponsored health insurance. They get proof through the I-9 process. That proofing event should happen once, right? Then they go to the health plan. They add additional authenticators on top of that proofing event, right? And that health plan then adds their member ID and group ID, et cetera, related to that. But today they do their own proofing. Then they go to the provider. The provider should never have to do any of this, right? This should have all been done upstream. Even if you're in Medicare or Medicaid, all done upstream, right? So the idea, healthcare.gov does it today. Healthcare.gov is the ACA legislation where you can go on, 20 million Americans get health insurance. They do ID proofing. So we're talking to them as well. Like, let's just establish it once, and then let's federate it across the system. It isn't as complicated as we're making it out to be. Here, one final point, this is really important. The reason that this hasn't been addressed since right now is because there hasn't been a business case to do it. Okay, in fact, the business case was completely antithetical to sharing data. It was, if the more data I have, the more money I make. Now, the business case, because of the way that the government is and private sector are now financing healthcare, it's actually more advantageous to have data across systems. So everyone wants access to the data. They have a business imperative now to get all the data from all of your plans and all of your providers. And obviously the consumer always has had that incentive. And so what's really important is there's a financial motivation to make this happen. But there's also a series of use cases that need to be solved with regards to the third-party app community, which haven't been involved in healthcare at a significant level because they haven't had the APIs to make that happen. So there is now this ecosystem that's occurring because of financial motivations.
Yes, there's a question here. Oh, I'm sorry, there's a question right there.
Mike, so I'm just going to make a very quick statement. It's Colin Wallace from Kantara. Just to pick up a point that Eve made there, she was trying to say right at the end there that, you know, a lot of this, some progress has actually been made in the standards and the approach and the concepts. And, you know, as an industry, I think, you know, we're running out of time to talk past each other. If we've got some solutions already in play and they're open, God help us use it, you know, because really there's not enough time to talk past, have politics in the way so that stuff is replicated and duplicated because it's just convenient for certain groups of organisations to do that. Please go past that and try and complement the work that's already done with work that, you know, where the gaps that there still are, and just concentrate on filling those gaps. Thank you.
Good advice. I had a question over here down front, and then you.
I didn't go to boot camp. I have a question and a statement as well. So the first thing is, I think I'm just trying to understand what is the crisis in the healthcare in the for the digital identity. One thing I'm understanding, and tell me if I'm wrong, is that we don't have a national identifier. That's pretty much it, and that we're trying to link the patient across all the organizations that they work with. So the idea is, one is that piece, right? Where it's missing is I, as a patient, should be able to, when I go to the doctor, my doctor should be able to access all my record. And so it's nothing different than what's there currently in the market for the other industry as well. It's very common in other industries as well. So it's what I have seen in healthcare. It's not that the technology is not available. What I'm seeing is the adoption of the technology by the healthcare applications. They are very, very hesitant to move forward. So that is I feel is more of a challenge than what is available. Because if you just look around in this identity, it's all available. But the problem is that the healthcare application needs to move up and actually focus on security, because that's one thing they don't focus much on. They're more towards the healthcare records and other stuff. But on the security side, I've seen that they do lack. That's right. But I want to understand, is there anything else I'm missing in terms of digital identity? What are the other problems or challenges in digital identity that we're talking about besides having a common identity across for the patient?
I think you're right in saying the technology is available. It has not been deployed yet, so they've not leveraged the technology. And I think one thing that, at least from a government perspective, we're trying to do is establish sort of common agreements, a trust exchange framework, which sets some basic, is voluntary. And of course, organizations like Karen can do probably a better job in scaling that agreement or scaling the framework and making it more market friendly and more usable, because as a government, we can't really spend too much time building a module. However, just establish, ONC has a rule out, it's called TEFCA, Trusted Exchange Framework and Common Agreement. My colleague spoke about it the other day, Tuesday night. It really is about establishing baseline standards for connectivity, establishing the rules of the road, rules of engagement, establishing an overarching organization that would oversee this rule, because it's not that the technology is not there, it's the ability to adopt the process, go with the flow, and ensure that whatever I use, the other organization can leverage, and we can scale trust, we can scale connectivity, we can access the right information, and that's what has been lacking so far. We have the systems in place, we just don't have a way of establishing connectivity without one-off agreements. So we're moving away from organizations having this one-to-one agreements to really trying to scale the agreements beyond just a few organizations and really ensure that the patient, the consumer experience is better, improving ease of use, ease of adoption, and really overall health, like the healthcare sector needs an overall reduction in costs and improvement in services.
And I would say it's not just the two provider parties that need to exchange the data, or the payer and provider party. It's also you as the patient wanting access to your own information. And today, if you have some data at LabCorp and you have some data at Health System A and at your dentist and wherever your health data is, right now you have to go to each place to get it, and the hoops that you have to go through to get your data, to identity proof yourself again so that you could get a copy, which by the way might be mailed to you on a piece of paper, is not the way this world needs to work. Oh yeah.
Right.
Yeah.
The adoption by the healthcare systems to actually use that.
Right. It's now that we're in the portal era, we
Yeah.
have logins. Who was it called? It portalosis?
I like that.
Inflammation of the portal.
Rita, you had a question?
Actually, Rosemarie, based on what you just said regarding TEFCA, I was curious if you envision. Oh, thank you. This is Rita Twerks today with the Pew Charitable Trust. I was wondering if HHS envisions like the recognized coordinating entity under TEFCA to be that organization to perhaps develop that process that you guys have been talking about potentially. But then I also wanted to bring up something interesting that I heard on Tuesday from another session, that authenticators do not necessarily prove identity. And I don't know if there's something to consider in terms of like the, how you view that, particularly when it comes to record matching, which is what I focus on, and being able to like correctly make those links.
So to answer the first question, and you're right. We have an overarching it's called RCE, that we've assigned as having overall responsibility of all the quality health information networks. So there'll be an overarching body, and there will be a group of health information networks that that body will oversee. In terms of the detailed descriptions, I don't know how that would scale. However, with private sector collaboration, I think that's something that if the government has a foot in the ground, and with alliances like Karen, we can move forward in terms of establishing baseline rules of engagement and rules of the road.
And in your second point, authenticators don't establish identity, but proofing events do, right? So the idea would be, can we develop proofing events and multiple trusted authenticators, right? Whether that's WebAuthn or whether that's, the ability to the national patient ID, if that goes to ability to make that happen, or all the other APIs that potentially could help from an authentication perspective, and then build up that credential over time to be more trusted.
Would you say that proofing events are foolproof?
Nothing is foolproof.
I'll let others in other industries decide that. It's not foolproof, but again, where are we in healthcare, right? Let's make sure we know where we are. Where we are is we have a bunch of usernames and passwords that we are exchanging using a technology called SMART across different systems to gain access to the data. That's where we are today. Now, just the concept of us saying we need an IAL2 certified credential and we need to make sure that that healthcare gets to an AAL level 2 or higher, that is a mind-blowing concept. Okay, I just want to make sure we know where we are.
Yeah.
Steve's mind was just blown.
Yeah. Lots of people.
And the idea of OpenID Connect, right, and OAuth 2, et cetera, the rules have come out in the last year that have just started that as part of the overall healthcare dialogue. Obviously, there's individual players that have been doing this for a while, but I'm just talking about general overall healthcare. That's where we are. So we're not going to solve every problem, and it's not going to be perfect, but we need to get some basic blocking and tackling done before we kind of move to that
We need to
next
get
step.
started.
And this is what's actually so exciting, and maybe compared to financial services, given that there is FHIR, the FHIR API, with all of its data structures, there's an open API that has actually been proven to really have something to it. And all the hackathons that I've been seeing over the last 3-4 years, really, it's significant that there's an open API that works, that we really need for those open ecosystems to flourish.
To Eve's point, just so you
semantically.
understand, like this open API was established by a group of folks that were around a dinner table, right? Literally, now they didn't develop it that night, but the idea was hatched that night, right? 18 months later, the API came out, and 18 months after that, we had 89% market penetration for this one API. So within 3 years, we had 89% market penetration. That's profound, and I say that because there are different industry consortiums working on the API issue to standardize that. APIs, I think we're well on to the races to make that happen. Digital identity, we're well behind. So other than the folks that are on this stage and a few other handful of folks, Collins in the back, and others that have been really intimately involved with this, there aren't enough people talking about identity and the link to APIs. We need to have more of that dialogue.
And just to contrast in like financial services, where jurisdictionally you have differences in how bank accounts and pension accounts and things look in different countries. And if you were to go cross-border, you have to do a lot of translation, whereas EHRs can be a little bit more standardized, I think, internationally.
A question over here?
Yeah,
Yes.
hi. It's more of a comment listening to this. It does seem to me that your fundamental problem is an identifier problem. Identity is something that can be layered on top of that, but identity assumes that your individual patients are going to steward this, maintain their logins, use them consistently, etc. There are other communities of practice, so it might be heresy to say it in this room, around large-scale distributed identifier schemes, things like the peered persistent identifier community, digital object identifier system, and I'd encourage you to look at those things as well, because identifiers don't have to be centrally issued anymore, right? Mm-hmm. And there are schemes out there that issue these things on scale and make them interoperable. So I think that it's probably an easier place to start in solving your problem, to look at digital identifiers rather than starting with the problem of digital identity.
Yeah, and just to be really clear, I don't think anybody that's on the stage are saying we need centralized identifiers. We're all in agreement there, but we do need an agreed upon process for how we're going to actually issue the identifiers and link it to a proofing event. Just want to make sure we're clear. I think that that's really important, because otherwise we get back into the same problem we have today. Yeah, I agree with
Yes, sir.
So, a lot of things have been talked here, and we have the government in the middle of this. So, question on the identifiers that we are talking about and issuing them to the citizens and everybody pretty much also overlaps with some other initiatives that have been in this field from the government side. At least in the U.S., they were not trying. I mean, the U.S. government was not trying to issue the IDs, but in EU, they went ahead and issued the EID cards. So they thought that that's probably the best way to kickstart this much faster than waiting for the private sector to kick in. So is the plan here to kind of go ahead with the healthcare sector identifiers and maybe then see how they can be used in some other sector down the line? Or is the government also trying to kind of lay out a plan where citizens don't get bogged by this number of identifiers they're carrying around, but they can be somehow portable across?
Yeah, go ahead. Go ahead.
Well, no, from the government perspective, I think the goal is not to really work on specific identifiers, really to enhance data sharing, improve interoperability, the ability for especially a consumer to have records across diverse unaffiliated health entities when they need it, and for the ability for transition of care to work appropriately so that when you go see a specialist, the specialist can call your record after the consents, of course, are provided if it's necessary for certain conditions as needed. So the government's interest, I know CMS does have their own identifier coming up, which is for Medicare beneficiaries. They are getting away from Social Security as part of a congressional mandate. So the government, again, has different angles in which they handle things. CMS has a core reason for going with a Medicare national identifier, alpha, I think it's an alpha and uppercase numbers, 11 characters, which is already being implemented or moving away from social. And that's really to drive their payment process and to improve claims collection and to reduce fraud. So they have rationales for doing that. But what we're talking about is really to improve data sharing, to enhance, to reduce the burden of transactions. As a consumer, I don't want to have to get proved or authenticated 100 times if I have lots of records all over the place. It's really to improve connectivity and establish trust so that I can easily streamline the process of getting access and get access at the right time when I need it.
And the private sector isn't waiting for government. This is a real collaborative partnership that we've developed, right? Private sector needs government and government needs the private sector, right? So especially in healthcare because it's such a distributed environment. So I don't think government wants to get ahead of the private sector. And I also think that the private sector needs to get to a point, it's my personal opinion, but needs to get to a point where they can lead and take the charge. And you mentioned proof of concepts. Like we need to have a lot of proof of concepts and look at ways in which we can make this happen. And if this looks like it works, then I think the government becomes a supportive partner to say, let's raise the floor, the regulatory floor, so everyone could implement some of these ideas.
A question
make that
here.
happen.
So moving away from identifiers for a moment, thinking about patients and different attributes that are hanging off of them, like imagine, for instance, the opioid crisis. Some patients maybe don't want you to know that they've doctor shopped and gotten 3 opioid prescriptions. So how do you balance the idea of, sovereign identity versus, healthcare providers needing to do their due diligence and putting some controls around it and limiting of fraud or addiction?
Mm-hmm.
So in the Karen Alliance, we've developed what we call our code of conduct. It's on our website. You can take a look at it. It's got a lot of GDPR principles and HIPAA principles in it. The idea is that it's all based around informed consumer consent. So the idea that the consumer can make these decisions on their own in an informed way. And then when they share their data, once they get identified, et cetera, and they share that data, they can make those active choices, informed, really active choice, to be able to say, this is the type of data I want to share, this is the type of data I don't want to share. And each time right now what you do is you fill out a clipboard in our doctor's offices and nobody really reads it again. So that becomes a real problematic way to share data. Let's see if we can.
And I just really want to make sure we know that if you're going for treatment or payment or health operations, there isn't a reason for a doctor to get consent from you to see your entire record. It's very important for the doctor to have visibility for different purposes. However, when it comes to treatment and substance abuse, alcohol, there are some regulations around that. But in general, if you're going to a specialist, he has a right, if he's treating you, to see your record even without your consent. And the whole idea is to improve the health of the nation, and it's really to not to have those consents that are not necessary impede treatment.
And that's a high-risk transaction you're talking about, prescribing an individual an opioid. So if that individual is not willing to share their identity, then that can pretty much stop the process in its tracks right there. I mean, I can't prescribe you. I can't even get Sudafed without showing my pharmacist my driver's license. So, I mean, yeah.
So maybe a good way to summarize is
Time.
all of that kind of sharing it's a reminder that it's a two-way street. And I'm going to say the relationship word again.
Thank you very much for coming.
Everybody.